Hi everyone, I want to talk to you about appendicitis. You've all heard about that? Okay, let's go. Appendix is a vestigial lamiform structure located at the base of the cecum. The tip of the appendix could be either retrocecal or pelvic, iliac, or subcecum. Inflammation of the appendix is called the appendicitis. It affects anyone between the age of 1 to 35. Neonates are not left out either, although it's very rare in neonates. More males suffer this than females. About 4 to 7% of the entire population could be affected, and 75 to 85% will be between the age of 5 and 40. The trouble will start with the obstruction of the lumen of the appendix. The obstruction is mostly due to fecally and is called appendicularly. It can also be obstructed with calculum, that is stones, or fibrosis, stricture, tumors, lymphoid aplasia, infectious process, parasites, or foreign bodies. You can see large number of items here. The obstruction will lead to bacterial overgrowth, and that will lead to inflammation. When inflammation sets in, there will be secretions, and the secretions will lead to swelling. The swelling will lead to increased pressure, and the pressure will lead to ischemia. Ischemia will lead to gangrene or perforation. Localized abscess is formed from inflammation, and necrosis will ensue. To those who have perforation, peritonitis will be picked. And the bacteria implicated here are Escherichia coli, Peptostreptococcus, Bacteroides fragilis, Pseudomonas aeruginosa, and the likes. Note this: if there is pain before nausea and vomiting, it is likely a surgical condition. But if there is nausea and vomiting before the onset of pain, it is likely a medical situation. The pain of appendicitis will mostly begin at periumbilical region, non-specific to that region, and later will localize to the right iliac fossa. There's likely going to be anorexia, and then nausea and vomiting. When we pick fever here, it's not going to be high grade, it's going to be low grade. And the temperature will mostly be around 38 degrees Celsius. However, if higher temperature is picked, it's likely perforation had occurred. Marked and localized pain in right iliac fossa is giving a clue that the appendix is anterior. But when the appendix is retrocecal, the pain is mostly going to be dull and achy. At McBurney's point, there's possibility of McBurney sign once the opening is at the McBurney point. Rosen sign will elicit pain on the right when the left side is triggered. I mean, when you palpate or you push from the left side of the tummy, the right side, particularly the right iliac fossa region, will experience the pain, or the patient will tell you he or she feels the pain there as Rosen sign. Psoas, on the other hand, is done when the patient is lying supine and he or she is asked to extend the knees and flex the right hip. When the right hip is being flexed, the examiner will apply resistance against it. And if there is pain elicited at that time, it's likely the appendix is retrocecal. Obturator sign is done with patient is supine, the knee is flexed, and the examiner passively, externally and internally rotates the hip. Any pain this time will be suggestive of pelvic appendix. What are the possible differential diagnoses here? Because it is not all the time that the right iliac fossa pain is diagnostic of appendicitis. Could be perforated appendix, well, probably from appendicitis or other reasons. Could be Crohn's disease. I have made a separate presentation on Crohn's disease before. Please check that out. And could be Crohn's because Crohn's can affect any part along the gastrointestinal tract. Diverticulitis is very common on the left, but that is not to say it can never occur on the right. It could occur on the right as well. Acute ileitis, that is inflammation of the ileum, could be the case. Pelvic inflammatory disease in females affecting the tube along that part on the right side. Ovarian torsion when the ovary on the right is suffering from that, including ovarian abscess. Ectopic pregnancy on the right could present like that. And of course, the kidney stone on that side could present the same way. Testicular torsion in men and endometritis in women or epididymitis in men. How do we make the diagnosis? In many parts of the world, it is clinically diagnosed. From the history of pain, before nausea, vomiting, or anorexia, periumbilical pain, localized to right iliac fossa, you do your Rosen, psoas obturator, and you make your diagnosis clinically in many parts of the world, particularly where the facilities to do other things might not be available. They can just go ahead with appendectomy with clinical diagnosis. But in advanced nations, the Western world, you do CT scan, do ultrasound, and of course, the woman will have, or the man will have laboratory investigations, but the woman will do beta human chorionic gonadotrophin if she is within the childbearing age. Why? We want to be sure this is not ectopic pregnancy, or she's even having the normal pregnancy, and you want to make sure you're not going to tamper with that pregnancy in any way. Do complete blood count with differentials, check the electrolytes, urinalysis, and clotting profile. Why? Might go in to operate right now. The treatment, to narrow it down, the treatment is appendectomy, mostly, and that is the gold standard. Any other stuff that I'm going to talk about is secondary. Major treatment, the definitive treatment for appendicitis is appendectomy, and that is the gold standard. However, you can have diagnostic laparoscopy with laparoscopy appendectomy, and that is advantageous for young ladies and obese patients. You can perioperatively give antibiotics, and the antibiotics could be selection of Vaseline and metronidazole if it is uncomplicated. You are going to pick metronidazole because you might be dealing with anaerobes. Some will give tazocine, that is combination of piperacillin, tazobactam, at a dosage of 3.375 grams intravenously every 6 hours. You can choose from the fluoroquinolones and the cephalosporins, but just make sure you are covering anaerobes along as well. You give antibiotics, open or laparoscopy appendectomy with peritoneal irrigation and drainage if it is perforated. If patient is stable and refuses appendectomy, give only antibiotics. Then make sure the explanation and education on possible trouble he or she may run into is adequately passed across. Any abscess must be drained, either percutaneously or as the surgeon may choose, or as the protocol is at the center. So the core of the treatment is back to appendectomy, and that is the gold standard. It's possible you have what we call appendicular mass. Appendicular mass in some parts of the world could be treated using a regimen called Ushner-Sharing. In Ushner-Sharing regimen, you admit, give your intravenous fluid, give analgesics, give your antibiotics, monitor the vital signs, and do one extra thing. Mark the size of the mass on the skin and watch out for reduction in size and signs of inflammation. Note, early appendectomy is better than Ushner-Sharing regimen, but most places, most centers in some other parts of the world will want to apply Ushner-Sharing regimen before they do anything else. But in many parts of the world with advanced technology and all the support, you just go straight to early appendectomy. Prognosis. The prognosis is worse if there is perforation. In that case, about 0.5% will die if there is perforation. The mortality is lower if there is no perforation, and it stands at about 0.08%. So do everything to get the appropriate intervention so that there's no perforation, because you stand the chances of dying if there's perforation. What are the possible complications? It is possible to come down with intra-abdominal abscess, and I've just talked about that a while ago, that drainage must have, anywhere there is abscess, it must be treated with incision and drainage, covered with antibiotics as well. It's possible to have stomach leak or perforation, in which case there will be peritonitis, and you just have to act quickly, or else the patient will be dead. I've just mentioned peritonitis. Sepsis is possible, and phlegma and appendicular inflammatory mass is also possible. Like I've said, it depends on the presentation, whether presented early and intervention done early, or complications set in and is beyond control, and unfortunately, the patient is dead. So death is also a possible complication. Yeah. In conclusion, to delay presentation may mean speeding up to the grave. Please, don't self-medicate in any way. Just present to your doctor, let the assessment be made, let the diagnosis be made, let appropriate treatment be embarked upon within the shortest period of time. So act quickly and be alive. Thank you for listening to my presentation. Kindly subscribe so that you can get all these immediately they are published. Thanks.